Diane that was here Friday night, she taught me this, is lots of times you'll get some good movement in the wrist, the radial head's working right and everything, but it just feels like there's a lot of tension in that distal forearm. And if you just grab the radius and the ulnar, and then try gliding the radius up and the ulnar down, then do it the other way. And take it where it wants to go, and then put compression in. And I think what that does is really change that interosseous membrane. And I think lots of times that's what's maintaining a lot of this dysfunction. And if you do that, get the radial head working, get the interosseous working, get the carpal bones working right, boy, people's hands and wrists can change tremendously. Okay? So now,
just work up to the elbow. You just on that.
yeah, and you can work right up the arm. Palpate, you may find the most tension in the mid part of the bone, and then get on either side and do it there. The other thing we didn't talk about is you can get inflared and outflared ribs. And these would be the lower ribs. So when you check them, they can be bucket handle fine. And the upper ribs are pump handle. Everything seems right, but it just seems like, man, there's something crazy going on here. And so what you do is just reach underneath. And you get your hands on the front of the rib cage. Now take a deep breath. And what you should feel is both hands should come out with inspiration, both should come in with exhalation. Now frequently what you find is one side won't go out. So one side will go out, the other side just sits there. And usually that, Mitchell used to call it a compressed rib. And where you can get those lots of times if you have a traumatic blow to the anterior rib cage, and it can literally spring that, the front of the rib posterior. And so then it can't come out with inspiration. So think about then, what are you trying to do? You want that front end to come out. So how you do that is you want to reach around, and you don't want to have any contact with the front of the rib with your forearm. You want to get that away and get a pressure right in the mid-axillary line and pull in towards you. Then have the patient take a deep breath. See, and what you're doing is you resist the rib going laterally, and it can't go posterior because the only thing it can do is go forward. And a lot of times, boy, those things will spring right out, and then they'll say, boy, can I take a deep breath, because then the diaphragm can work a lot better. Okay? So that would be the compressed ones. And what you'll feel then when they breathe, with those people, this side will come out. This side will usually go laterally, so it goes, instead of this, it's, okay? Then sometimes what you'll find is they go out well, but they won't come in on one side. So that would be a group of ribs that are outflared. So then how you treat that is get your posterior hand right at the angles of the ribs that are involved in that. Reach the lower ribs here. And then you kind of position where you feel, get them where you got everything localized there. Then say to the patient, take a little breath, let it out. Now you try to turn to the right. And I resist, so I'm pulling medially with this hand, pushing laterally with the posterior hand. See, and what you're doing is flaring those ribs in. And boy, and usually what that'll do is it'll affect, cause a band along the lower thoracic area, like everything. It just doesn't come out when you get the thoracic area working, the rib cage working. So then start thinking, I better check those ribs for inflares and outflares. And they can be big ones. Okay, so you're going to check your partner's upper